social care work here at Policy Exchange. Now, Policy Exchange has had a packed fringe programme for this conference. I'm sure hopefully you've come to many of our events, but this is the one that I'm most looking forward to, which is in conversation between the Health Secretary, Sajid Javid, and Fraser Nelson of the Spectator. Now, I believe on Wednesday it will mark 100 days since you were appointed as Health Secretary. So it should be a really timely moment to discuss your vision for reform of health and social care, of which Policy Exchange is hugely supportive. So I hope you'll join me in welcoming Fraser and Sajid to the stage. Thank you.
Thank you. Right, well, Saj, first of all, welcome home. You're kind of from here, aren't you?
Not far, which 10 miles from here, I think Rochdale.
Do you think of it as home?
It feels like coming home, yeah, especially because I went to see my aunt earlier a couple of days ago, got some samosas and pakoras in, and that definitely makes me feel like home.
Right. This is your 6th cabinet job, isn't it? I was trying to count them.
6th department, yeah.
Yeah,
right.
So Culture, Business, Housing, Home Secretary, Chancellor, and now Health Secretary. Now, Business and Chancellor, you're semi-qualified for them. You used to be in finance.
What do you mean?
Well,
I don't think I want to do this.
It's not exactly the same thing, is it, making a few bob in Singapore versus... Anyway, but then you were, as Home Secretary, you've got your brother who's in the police, you had some family knowledge of that. But when it comes to running the health service, the biggest organisation in the world, I think, apart from the Indian Railway and the Chinese Red Army, you have got no health experience at all, am I right?
I've got no direct health experience at all, no, but that's not unusual for a health secretary. Right. It's not unusual for most cabinet jobs.
Sure, but what about if you... I know, when's the last time you were in hospital? That's a delicate question. No, because I ask you this, right, because Nick Robinson, I read...
I visited the hospital the other day.
Yeah, but you told Nick Robinson that when you were young, you were in hospital, and the nurses thought that they'd left an instrument inside you, and your mum was terrified.
So the last time I was admitted to hospital, that was, I was about 5 years old in Rochdale. And in fact, I've got the, of that particular incident, I've actually got my mum heard that interview and she said, you didn't get it quite right. It's actually even worse than you thought it was.
Worse?
Yeah, and the incident, so I'll tell you what happened if you want to know very quickly, is that I was feeling really unwell, and I can actually remember this because it's so painful. I remember my dad sort of carrying me around the house and things and called the ambulance. Went to the hospital. It turned out to be my appendix, which was removed. Next thing I remember is being back at home, in bed, being cuddled, teddy bear, samosas and pakoras again, and feeling much better. Yeah. But then a couple of days later, my mum says, you start to deteriorate again. I don't remember this bit quite. She said, and then all of a sudden, one evening, you're crying out with pain, and it's like we don't know what's happened, but you're supposed to be getting better. And they call the ambulance. I go to the hospital, and they do a scan, and it turns out they left an instrument inside me. Yes.
Really?
And so,
what sort of instrument?
I don't know. My mum couldn't remember. She thinks it was a pair of scissors, but isn't sure.
So how old were you at the time?
5. And so,
pair of scissors and a 5-year-old kid is...
Yeah, next time, and maybe they would have come in handy in the future if it was about the next time I had to cut a ribbon or something. Yeah, you said, but and so they actually found an instrument, and that's obviously what the problem was.
So you went back
that was the last time I was admitted into hospital.
Okay, so
that's my experience.
So you had a little bit of the NHS inside you for a few days then, huh? Right. Okay. So, but now you're in charge of a massive organisation, and how do you approach this? I guess you'd approach most jobs, right, by applying your political principles. So, in this case, what principles will you apply to this job?
Well, the starting point for me is I've always, even before I got involved in politics, believed in the NHS and what it stands for, and its core principles of being there, proper world-class healthcare for everyone, free at the point of use, paid out of taxation. So that is a fundamental principle of the NHS, and I very much see my job is to make that work in today's world, but especially in the post-pandemic world, which I think is fair to say has led to even more health challenges than we'd had before. And I want to make sure that hopefully I'll get a bit more time in this job than some of the other jobs you referred to. I have a few years in this role where I can learn from the pandemic and make sure, I've got 3 priorities, make sure I can deliver on all 3, which is to COVID, to keep the virus at bay. It's recovery, especially around the waiting list in the NHS, and about reform. I want to make some fundamental, I think, far-reaching reforms that my view is I think they're absolutely necessary if we want the NHS to deliver for everyone and to be sustainable.
Right. So what kind of, would you say you intend to be a reforming health secretary then?
Yes, you could. I want to be a big reformer for the NHS and for social care.
Right.
And I want to, as I say, I want to have the time to do the job, to do it properly. Because look, the last 18 months have been difficult for everyone. It's changed the world. The pandemic has changed the world, and it especially has had the biggest impact, as we would imagine, on healthcare for us, our loved ones. We've seen during that time how anyone, whether they worked in the NHS especially, and social care, how they really rose up to that challenge, did incredible work. But we've also seen during that period not just the impact of COVID, but actually, let me put it this way. I think some people say that COVID was the great leveller, right? And I think it was anything but. What we saw during that time, I think it was actually shone a bit of a light on the disparities in health outcomes that were always there. And we saw them through COVID, I think, in a way that we haven't seen before. And I want to address these long-standing disparities and at the same time make sure that we reform the NHS so that regardless of where you live, regardless of which community you come from, that you get the same high quality of healthcare, and that's not true at the moment.
Okay. So you're saying that lockdown affected people unequally then?
Yes. Yeah, it did, and we can see that, for example, in the COVID sort of outcomes. Sadly, if you look at the death rates or even people that were hospitalised, it affected certain communities harder. If there are people with some socio-economic backgrounds where maybe let's say they're working frontline jobs, working public transport, working in the NHS, social care, they were hit harder. People from certain ethnic minority communities were hit harder. I don't pretend I've got all the answers as to why that happened, but I want to understand them and act on them. It's one of the reasons I've created the new Office for Health Improvement and Disparities. There's a unit to just basically find the very best evidence, both at home and learn from abroad, to really work on prevention as well. Because obviously the reform that top of my mind is the NHS and social care, especially the integration between the two as well. But if I sort of step outside that immediate focus, the external sort of influences of prevention. I was looking the other day and speaking to my team about what more we can do with prevention. And one of them pointed out, they said, the NHS spends 5% of its budget roughly on prevention, but 40% of its budget on dealing with preventable illnesses. And so I just think there's something there that we can do more on.
Right, and how does that compare to other countries? I mean, isn't that the case for all health services, that, for one way or another, health problems are preventable? That's just not an NHS thing, it's just a global health thing.
Look, it's not just unique to the UK, but if you look at some of the disparities in outcomes that you see in our own country, I think it's fair to say that we have some of the sharpest differences. So I went to Blackpool recently to do a speech and talk about some of my plans around prevention. And if I just pick that Blackpool as an example, that if you look at the average healthy life years for someone in Blackpool versus Richmond upon Thames, the difference is almost 20 years. Right? So in our own country, it's 20-year difference. You don't even have to look between sort of Blackpool and London. If you look within London, if you look at the difference between sort of Bethnal Green and Westminster, I think it's something like 13, 14 years. So that's within the same city. So why do we have such disparities in outcome? And I'm not pretending there's one single answer, but I think that we are going to have a renewed focus on both prevention, but also within the NHS to make sure that the very best of the NHS is available for everyone. And that's where my reforms are going to be focused.
Right. One of the first things you reformed, I suppose, is lockdown, because when you were Health Secretary, we were in lockdown.
Yeah.
You then argued that we should end it to timetable. But at the time, this was very much against public opinion. I think something like 60 or 70% of the public were against ending lockdown at the time you argued to end it. Can you talk a bit about that decision? Because the country wasn't ready for the decision that you wanted to take.
Yeah. So, look, during the time I've had in government, I've learnt a lot. And one of those things is that you should really just, as a minister, you should really do, at the end of the day, what you think is right. Listen to everyone, get the best of evidence, and you've got to make a decision, because not deciding is a decision in itself. Right? You've got to make a decision. And so soon after I came into the job, this was a big decision that was already lined up, hadn't been made. Do we open up, the so-called step 4, or do we just delay it again like we had done just a few weeks before? And the sort of the advice we were getting was indecisive. It was depending on, I'm not sure that inside the government, but obviously there's a lot of people out there that had views, a lot of scientists, well-meaning, with their various different models. But the models were anywhere from people saying, look, if you open up in the way that we did, that you could have 20, 30,000 cases a day to 250,000 cases a day. And I had to take all of that into account and then come to a decision. And my view was that we're about to head into summer, and that means that not only is the weather more favourable for a virus of this type, kids are about to come off school, people will be off work a bit more because maybe they're on holiday, and taking into account all those factors, I thought if we don't open up now, we won't be able to open up till way after the winter, because then opening up in winter would have been the wrong time. That's when we're going to have to, in any normal year, have to deal with flu and other respiratory viruses, and then you're sort of into Easter, and so we could have been delaying opening up, I thought, then by maybe 9 months, and that's not something I think that could have been justified, certainly with what I was seeing. But also, I wasn't just thinking about COVID, because I've said it before, but it's really important to me. I'm not just the COVID secretary, I'm the health and social care secretary. I have to think about other health outcomes, and it was becoming even more evident that because of the lockdowns, we were getting hugely growing problems in mental health, undiagnosed cancer, in other cardiac problems and stuff, that people weren't coming forward to the hospitals, and it was really playing on my mind.
And you were saying 7 million missed appointments. You were saying
7 million. So at the time, I asked the team, and they said they think there's 7 million people that ordinarily would have come forward to the NHS to get the care that they would have expected, but they didn't. They stayed away. And in that, I was told that maybe over possibly as high as 100,000 undiagnosed cancers, and people were going to die because of that, because they didn't get spotted in time. The mental health problems, that's really, especially amongst young people. The increase, 30, 40%, in some cities, 50, 60% increase in referrals. And then also, I learnt this during my time in government, is having actually run other departments and thought about things from the perspective of whether it's a chancellor, a home secretary, a business secretary, a culture secretary, having thought, I know my job isn't just to be thinking about only my department and nothing else. I have to think about the country, the national interest, and think about the impact of the lockdown on education, all those kids that missed normal schooling, jobs, life chances, and take all that into account. And so in doing so, to me, that's what I had taken into account. I made the decision, and of course we've got to remain cautious about what happens next, where we are. But I think we, as a government, because it's not just my decision, rightly the Prime Minister is very involved in all this and takes it very seriously, as I do. And the decision we made, I think that let's remain cautious, but I think we've done the right thing.
Right. So when it came to lockdown and ending lockdown, there were risks on both sides. I've got here the SAGE scenarios that were published on the 7th of July for reopening on the 19th. Now, those scenarios ranged from peaking 27,000 people in hospital with COVID. That was the worst case scenario.
Yeah.
The best case scenario was, there's several scenarios, was something like 7,000. In the end, it came in lower than the best case scenario.
Yeah.
This fits a trend. Time after time, Sage has predicted scenarios. We've always come in at the bottom. Even right now, if you look at what's happening for winter, the Sage scenarios are, right now, one of the scenarios had 3,000 people in hospital, and it's new admissions a day, and it's far lower. Why do you think there was a Sage negativity bias here? Because it's quite significant. If we're getting advice from, if you do X and Y, Minister, these are the scenarios. It seems that every time the Sage advice was arguing for lockdown and wasn't really looking at the other side effects that you spoke about. But not only that, they were way off when it came to estimating the likely impacts of unlocking.
Yeah. Look, I mean, the first thing is that they're an independent group. They're entitled to come to their own decisions, and I'm entitled not to listen to them. And because I'm a minister and I have to make the decisions. The Sage or any other group for that matter, as well-meaning as they are, it's not their job to make these decisions. And I think it's just important that any kind of advice that you receive as a minister like that is that you listen, you absorb it, but then you've got to come to your own decision. I mean, had I listened to that, lots of things, but we certainly wouldn't be meeting like this now and having a conference, and the people wouldn't be getting together with their friends, their family, in the way that we are in what I think is a safe way. Why? Your question also was why. I mean, I don't know. I mean, I don't. What goes into their model and what influences, I don't know. I think one of the things that I would say I do know now is that we need to learn from this and make sure that whether it's future pandemics or just epidemics and things, that we just have a better way to, as best as we can, to try and forecast the impact of certain decisions. We will learn a lot from this, there's no doubt about that, but I can't try and guess why they sort of come up with these kind of views, and obviously earlier on in the pandemic, I wasn't even in government then, so I wasn't really sure what motivated them.
But when it comes, of course, you're I'm not saying there's going to be another wave of COVID, but it makes sense to prepare for what happened if something like this were to happen again.
Yeah.
So do you think that in future, the modelling should also include the side effects of lockdown? You mentioned 100,000 mental health cases undiagnosed. That's not something we saw on any of the many slides we saw on the number 10 briefings. The whole side of that was almost no attention on that whatsoever. It seems to have been focused on the damage that COVID would do, fair enough. But there's always a balance between that and the harm that lockdown would inflict. We never seem to look at all at that until you came along and gave your figure of 7 million missed appointments and the things which flow from that. So do you think there's the potential to move to a more mixed, a more broadly based mode of risk assessment when you come to public health interventions?
Yeah, I do. I think that we've got to, as we have been doing recently, is take a broader view on just that narrow focus on this virus itself, and then also I think sort of communicate the as politicians, I think communicate well to the public about the choices we face as a country. That it's not black and white. It's not just about COVID, and now that we have tools that we didn't have certainly at the start of the pandemic, even at the beginning of this year when we just got the first vaccines, and that we have far better treatments than we ever had before. We've got new treatments coming online all the time, some amazing new treatments coming online, and the testing regime that we've got, which makes a huge difference. Do you know, for example, that on a daily basis, a quarter of the positive cases we pick up come from the asymptomatic testing that people do, or from the lateral flow tests, right? So we pick them up, those people can isolate. So vaccines, treatments, testing are our lines of defense. And this is what means that we can now learn to live with COVID in the same way that we've learned to live with other viruses like flu.
Okay. You mentioned that we might not have been here today had lockdown continued. There was a prospect of us all having to get vaccine passports to come here. That was very much on the agenda. Until you sat in Andrew Marr's sofa and said that you were not going to go ahead with it. What was your rationale behind that? Because vaccine passports have been used in France, they're being introduced in Italy, in Ireland. Why did you think they weren't appropriate for Britain?
Because I'm driven by the evidence. And if you look at countries that have, so you mentioned France and Italy, and they're good examples, I think from the evidence, and I'll speak to my colleagues, the ministers in those countries as well, is that their motivating factor was to significantly increase their vaccine take-up rate. We have been much more fortunate when it comes to vaccine take-up. In the British public have been very supportive in general. I mean, there are pockets of vaccine hesitancy, of course, but very supportive of the vaccine program. We don't have anything like the kind of hesitancy that you've seen in France and even Italy, but typically in France. And without tools like vaccine passports and things, we've seen a take-up rate of over 80% of over 16s, double jabbed, 90% of at least single jabbed, and those are phenomenal vaccine take-up rates. And so, if you speak to those ministers, they would tell you their motivation was trying to get vaccine take-up up. And so, given that we didn't have that same issue, I don't think the evidence would have supported introducing vaccine passports for that reason.
It might be even higher. I mean, the argument is that that the French were trailing the European average until vaccine passports came along, and then they went higher than the European average. And also, if you look at, take for example, young people in Britain, are very low vaccine uptake rates, and that was the issue, that if we told them that we wouldn't let them into the nightclubs, then they might change their minds. I mean, right now I've got the figures here. Almost 40% of under 30s are unvaccinated versus 4% of people over 60. 40%, that's 2 in 5 young people. Had you put in vaccine passports, wouldn't that figure have gone up, and wouldn't that have been public good?
Look, it may have gone up a bit, but I don't think if a country introduces vaccine passports, I don't think the motivating factor should be to drive up vaccination. People should take a vaccine because they want to, for a positive reason. In our country, we've seen just the difference it's made. That doesn't mean to say there can't ever be a role for such an intervention, but I've said before, and I'll say again, I think if you did that, the bar to do it has to be very, very high, right? Because in a free country, if you're going to do something like that, then you just have to have the evidence to back it up and to show why it's going to help the public in some other way where there was no alternative. We are, especially as conservatives, we're a freedom-loving party. Our default position should never be state intervention. Our default position has to be to allow people to help themselves, to support them where we need to. Obviously, in a pandemic, there had to be a level of state intervention like we've never seen before. I think the vast majority of people understand that, and they respect that. But when we're in a much better place today with the vaccines, the testing, the treatment, if we're going to start just take away people's freedom, you've got to have a really, really good reason to do it. And I don't think we have that reason at this point.
One of the things that we've seen, not just in Britain, but all over the world, is a really quite significant and persistent gap in vaccine take-ups amongst ethnic minorities and whites. Yeah. And the figures are really quite striking. Why do you think that is? Why do you think that black Britons are something like 10 times more likely than whites to be unvaccinated right now?
Well, first you're right to point at this. And it's basically in all ethnic minority communities, but particularly Black British or Black Caribbean, and it's true in many countries. And from myself also talking to people from those communities, from others that have worked with those communities, there's clearly a higher hesitancy rate, and there are, from what I can ascertain, there are some people in those communities that sort of pass around what I think are just wrong, false messages about the vaccine, and there's too much of that sort of false news about vaccines, and we've got to keep working hard at trying to sort of get the positive message across, to reach out to all communities, but particularly those communities, and that's both through information, that's through more trusted voices It's also through making access to the vaccine even easier than it already is. So we've got, for example, mobile vaccine vans that will go around and make it even easier, and just keep doing it again and again through persuasion.
Right. But it's interesting that when I looked into this phenomenon, I was really struck by it. I couldn't quite work it out. Now, perhaps it was linked to trust in authority. That's one of the potential factors. But then you also find out that the poor are way more likely to be vaccinated than the rich. There's really quite a striking gap there. And also, this holds true for childhood vaccines, for basic intervention. So does this cut back to what you were talking earlier about health inequality?
Yeah, no, it does. And what you're pointing out there is that even before COVID, we had these challenges. We may not have all sort of noticed them the way that we do now, and that's understandable. But if you look at those kinds of health inequalities I mentioned earlier, and you don't look back just 5, 10, 20 years, you go back 100 years, 150 years. It's the same parts of the UK often that have had these kinds of inequalities. I mentioned Blackpool earlier. If you look at Blackpool going back even 100 years, you see similar problems. Chris Whitty, the chief medical officer, he's done a lot of excellent work on coastal communities, and he was explaining to you, if you look at some of the health inequalities and you just look at the same sort of coastal communities, you go back 50 years, 100 years, you still see the same problems. So these are deep, long-term issues. So it will take me time to try and change that, but it's not going to stop me from trying to change that.
All right. One last question on vaccines. You're taking quite a hard line on care home workers who are unvaccinated. I'm not quite sure how many of them there are who are about to lose their jobs. It's thousands, perhaps tens of thousands. What do you say to the care homes who were really struggling to recruit in the first place, who are about to lose all of these care workers at a time of an acute worker shortage?
Well, the first thing I'd say to care homes, and especially care home workers, is thank you for the most amazing job that you did at the worst point of this crisis. And these were people that were literally on the front line. Many care home workers died when we didn't have vaccines and things because they were doing their job. And so I'm full of praise for what they've done. And those same care home workers, I talked to many of them, are the ones, the vast majority of the ones that take up the vaccines as soon as they were offered. They were in the first group back in January. They were rightly offered the vaccines. They've taken up because they understand that their job is to look after some of the most vulnerable people in our society, whether that's in care homes or in domiciliary care, and that's what they do. They understand that. And for that reason, the take-up rate is very good amongst care homes, and it's actually risen a lot since we introduced this new regulation.
What is it roughly?
Soon. It's for double vaccinated, it's about 85%, and for single vaccinated, it's over 90% now, 92%, I like to say. So so the legislation we introduced is working to push it up. But the reason I said what I did recently is that at some point, if you haven't got a vaccine by the time of the deadline next month, then you're probably not going to, you've had plenty of time. And there's been plenty of time for people to persuade you. And for me, actually, is actually quite simple, is that you are doing a job that is looking after some of the vulnerable people in society. And if you haven't got the vaccine, you haven't been persuaded by it because you are listening to these ridiculous theories on the internet or on social media and stuff that are just completely fake news, then really at some point you're just going to have to leave and get another job because you can't be looking after the most vulnerable people in society.
But that's an example of somebody who's listening to fake news. What about somebody who's recovered from COVID, has natural immunity, and doesn't see the reason why he or she has to take the vaccine? Why should they lose their job?
Well, if you are, so I know this isn't the point you're making, but there is an exemption, a medical exemption, because obviously there are some people who can't take the vaccine, and if you, so if you're medically exempt, then that's fine. Then of course.
So if you've had COVID, are you medically exempt?
No, you're not. If you have COVID, then you would still have to take the vaccine.
But why is that?
Because there's. Why not take the vaccine at that point? Why then?
If you're about to fire her, isn't it more incumbent on you to tell her why she should?
No, but if you exclude that person, then when do they take the vaccine? How long does that immunity last?
Maybe they don't. I mean, you'll have been familiar with a study in Israel, something like 2.5 million people, showing that those who were at a natural immunity those who had been vaccinated but hadn't had COVID were something like 5 to 7 times more likely to catch COVID than somebody who'd recovered naturally from it. So you've got nothing to go on to say that somebody who's had COVID poses any more of a risk. Yet that person is still going to lose their job because she won't take the vaccine. This isn't a public health argument.
Yeah, well, no,
It's
I
about
think that we have to, in making this decision, we have to keep it, especially in legislation, as straightforward as possible. And I think it is perfectly reasonable to say to someone in a care home who's been able to take this vaccine since January this year that if they haven't taken the vaccine, despite all the effort that's been made to persuade them, encourage them, provide them with information, introduce them to trusted people, trusted voices, that at some point you have to move on.
Right. So what about, why doesn't this argument apply to NHS staff?
It may do. I'm consulting on that right now. And I'm not going to prejudge the outcome of the consultation, but that's exactly what we're consulting on.
Because you've still got the same proportion, 92% versus by 8% unvaccinated. That's true for NHS staff as well.
The NHS vaccination rate is higher. It's the double vaccination rate, I think, is over 90% now. So it is higher, but it is not 100%, and that is why I'm consulting on a similar rule for the NHS.
Right, but you can't afford to lose 8% of NHS staff.
I don't think I would lose 8% of care workers, let alone NHS staff. I don't think that will happen.
What do you think is going to happen? How many care workers do you think you lose?
No one would be surprised to know that we monitor the situation in care homes very carefully. And CQC, an independent regulator, has a lot of information, care home by care home. And I think that the decision that we've taken and the tough line that we've taken on it will turn out to be absolutely the right one.
Right, okay. And so just for the record here, you basically don't buy the natural immunity argument. That's why these people are going to get fired if they haven't had the vaccine but they have recovered.
No, the reason why people may have to lose their job is because they haven't taken the vaccine.
Because you don't buy the natural immunity
Well,
argument.
because we've set the rules, and they are based on getting a vaccination rather than any other argument, unless you are medically exempt.
Right. Okay. So you said earlier on that as a Conservative you think taking the state should be the last resort here. But isn't there rather a lot of state in the healthcare provision in Britain? I mean, 20 years ago, NHS was something like a quarter of government budget. 10 years ago, that had risen to be something like a third. Now, soon it'll be getting on for 45% of the government budget. That's absolutely huge. So isn't the government, so we can see here, rather than try to find ways of diversifying healthcare provision, the government is just doing so much of it, and every single time you guys think of what to do next, your instinct is, let's tax more and let's increase NHS funding until the NHS is almost half the size of the entire government.
Well, I think most people understand that since the creation of the NHS, there's been two major driving factors that has meant that the NHS is trying to do more. One is, of course, lots of new treatments and medical breakthroughs, which are great, and you want to make sure the NHS can offer that to the British people. The second is demographic change. So even, I think, the next 20 years, the number of people over the age of 80 will double, something like that. So those two constant pressures are putting pressure on the NHS to its increasing demand. And of course, the government has to react, all governments, and this government rightly so, to make sure the NHS can meet that. Now, how you do that, there's obviously a question of resources, and we've recently, in the last few weeks, been talking a lot about that. I have, and others, about how we plan to meet that. But maybe this is the point, Fraser, you're getting at. It can't just be about resources. There has to be, and this is what I was touching on earlier, there has to be some significant reforms, right? So, for example, that makes that money go a lot further, and it doesn't just sort of constantly become about how can we get more money to deliver more. So digitization in the NHS, the use of tech, it's hugely varied from trust to trust. I've seen hospital trusts that every patient record is an electronic record. They're working with a local council, the primary network, and all of those together, one simple system with apps and stuff. It's fantastic, right, for the patient, for the clinicians, where the same trust where they're using robots for general surgery, which are not only cheaper and quicker, but they're safer for the patient The robot is safer than a human, and so that means the recovery for the patient is a lot quicker. And so that's happening in one trust. And then you have other trusts where it's hard to see how the technology has changed from the 1990s. They're literally using fax machines, right? I've seen that. And so you've got this within one system, this huge variation. The other thing is about leadership, and that's why I've announced this leadership review with Sir Gordon Messenger to look properly for the first time in 40 years about how we can take the very best of the NHS, some of the phenomenal leadership that we find, that I've seen, and replicate it throughout the NHS. And then the third thing is about integration, about the NHS and the social care system just being much more integrated because there's some obvious connections between the two. And in the past, we just haven't had those two working together with one or two exceptions around the country. Again, why can't we look at those exceptions that have worked really well and replicate that in the country as well? And so it's these kinds of reforms that we're going to have to make. And I think that we have to do it now. Now is the moment. I want 2022 to be the year of reform for the NHS and social care, because the pandemic has meant, I think, that people are more understanding of the need to have fundamental change in the way we approach health and social care in this country. Health has become the issue for every single person in this country in the last 18 months. And we should capture this moment now to set out these reforms and make these changes, because in the past, the way I look at it, governments have either, when it comes to the NHS, they've either sort of thrown cash at it or they've gone for the reform. But I think it's a false choice. It's got to be cash and reform together.
Invest and reform. But how much, I mean, we all know about the investment. The national insurance increase has put taxes up. By the way, against your manifesto pledge, a pledge which you, as Chancellor, worked hard to put in. Now, when you were, I hope it's not unfair to ask you this, but when you were Chancellor and you were fighting the election, you were saying, look, we need to put in a pledge here that we're not going to raise taxes. You know the argument against such pledges. The argument against such pledges is, well, you can't tell the future. You never know what's around the corner. You might end up like Nick Clegg, having to break your promise. And after that, your credibility goes. And next time you face the electorate, you will not be able to make any promises because you broke your last promise. So it wasn't just a manifesto pledge. This is one of the Prime Minister's 4 or 5 pledge card promises. No tax rises. How bad is the damage to your party's credibility, you think, that you've had to break one of those promises at a time where you knew, when you made that promise, you knew that anything could happen? That's why people would say to you, Sajid, don't make that promise, because you might have to go back on your word. That's exactly what happens.
I think it's fair to say that you know when any party puts together a manifesto, you know that lots of things could happen that you haven't foreseen. I think that as a general point, that's right. But I think it's right also to say that, I mean, I can't think of any manifesto in 2019 or before that talked about a global pandemic that will be the biggest health challenge in living memory, right? I mean, this is a seismic event, right? I don't think that's an exaggeration to say what COVID has done to the world, what it's doing to the world. So I don't think anyone could have foreseen something of such force hitting the world, not just the health, from a health perspective, but the global economy in the way that it has, and actually geopolitics in the way that it has. So I think it's reasonable, been perfectly reasonable for the government to say, as it has, we didn't see the pandemic coming. No one saw the pandemic coming. It has changed a lot, but it has also certainly changed the demands of our health and care system in a way that we could not have foreseen. And so to meet those demands, yes, we're going to have to do lots of reforms, but we are going to require to fund those demands. So, for example, we're spending billions a year on vaccines. We're spending billions on PPE, all these new treatments. They're costing billions, right? No one could have foreseen that billions that we're going to spend on vaccines. For goodness, people don't know for how long. And the government has to respond to that. And if you didn't do it by raising taxes in the way that we have, then the only way you've got to do it, there's no easy cuts, as it were, in government spending in other departments. So the only way you've got left is to borrow more on a consistent basis, and that's wrong. I don't think you should really be funding day-to-day spending, reoccurring spending, year after year, by borrowing, because all you're then doing is passing the bill on to your children and then your grandchildren, and I think that's wrong. Right? If we're going to consume these vaccines to look after ourselves, rightly so, then we should pay for them, this generation, and not ask the next generation to pay for them. And so all of that taken into account, I think we were right to be straight with the people about the challenge we face and say, yeah, you know what, we can't meet this manifesto pledge. We're not beating around the bush, pretending we met it, all that. We're just being straight with you, but these are the reasons we did it. And I think that's grown-up leadership.
Okay, on the subject of being straight with us, the money isn't for the NHS, is it? Not really. For the first couple of years, it's going to be used to put down the pandemic, but after that, it's being used to fund the Dilnot report and to care for the elderly. So, I mean, it's an easier argument to say that this tax rise is for the pandemic, but in that case, it would be temporary. It would disappear once you've got rid of the backlog. But the plan, surely, is after 3 or 4 years' time, it goes into long-term care for the elderly, which has nothing to do with the pandemic.
You know, the money for the spending round, for the sort of spending review period, the 36 billion, about 5 or 6 billion goes on the sort of the Barnett formula, so that goes to the devolved administrations, and I hope they spend it on health and care, but that's the devolved settlement, and that's up to them how they ultimately are going to spend that money. Then almost 16 billion there goes to the NHS directly. About 7 or 8 billion, using rough numbers, goes on vaccines and things which are ultimately part of the work of the NHS, testing. And then 5.4 billion will go to the adult social care system over that 3-year period. After the 3-year period, more and more of it will gradually start to go to adult social care. It's hard to predict that exactly right now, but I think it's right to with that funding, to support where it is most needed at this point, and that is certainly in the NHS, especially in trying to get through that, the backlog, and then gradually over time it will shift more and more into adult social care, and I think that fits in with the new system we're bringing into adult social care.
Right. Okay, one final question before looking up to the audience. You have always described yourself as a low-tax Tory, right? Let's set that aside for now because of exceptional circumstances that you mentioned. But you have also described yourself, all the time I've known you, as a kind of supply-sider, somebody who believes in supply-side reforms. Does that apply to health? Is there such a thing as supply-side health reform? Is that the sort of thing that you intend to do?
Yeah, I think there is such a thing. So maybe you can call it supply side on the public sector, in the kind of things I've been talking about in the past half hour with you. If you think about on the prevention side, for example, on the innovation, on the digitization, it very much involves your supply chain changes. It involves the private sector being involved in that innovation, delivering those robots, those new drugs, the treatment, and that is very much about the NHS and social care for that matter, but especially the NHS having a partnership with the private sector. So there's a huge supply side element to it.
All right, so if you're still Health Secretary, I don't know, say you last as long as Jeremy Hunt, okay? Nobody's lasted as long as Jeremy Hunt, but say you do. What sort of changes would we expect to see? No, let's say 3 or 4 years' time, if you stay in your job that long.
If you stay in your job.
Well, you're...
Yeah, that's a good point. I think that, changes. I hope that COVID is something that we feel that is behind us. It might still be with us. I think it will be as a virus, but we've sort of got it under control in terms of whether it's annual vaccinations, the treatments, and all of that. That in 3 or 4 years' time, that the backlog, which I've been clear about because of all those missed appointments, that it's going to go up before it comes back down. But we are well and truly dealing with a backlog, and ploughing our way through it with the innovations that I've been talking about. For example, the new surgical hubs, the community diagnostic centres, and all of that, new ways to do things. And that I can look back and think that I've made a set of reforms which will, yes, take time to settle into place, but they will set the NHS up and social care through the integration for the real long term, and mean that hopefully people look at that and think that they're going to get better health and social care than they would have expected otherwise without these reforms.
Okay, let's go to questions. Who would like to ask one? Wow, lots of hands. Okay, let's take 3 so we can get as many people as possible, and we'll try to be lightning fast with the answers. Okay, you got a microphone. So how does this work? No. Is there a policy exchange microphone in the house? There is. Okay, can you just choose 3 people you'd like to look off? Sorry, that's a bit mean.
Thank you very much, Minister. Catherine Johnson, Chief Executive of Volunteer Services, and we've been mobilising volunteers throughout the pandemic, 1.2 million of them to support the NHS, and now COVID vaccination processes. In your reforms and your things, it'd be really great if we could see parity of esteem for volunteers across the NHS who have brought a huge amount to COVID surge response and the pandemic. And moreover, if we could see them in the same sphere as the way the police and other state services like fire services, coast guards and everything have retained volunteers as part of the workforce. And whilst I accept blended workforce is a rude term in terms of NHS, actually the NHS staff will tell you they get a huge amount of support themselves from having volunteers in the environment.
And what do you mean by parity of esteem?
Parity of esteem, I mean that actually, rather than seeing volunteers as an add-on, could we please see volunteers at the forefront of the planning for integrated care systems, for social care reform, for looking at how volunteers can step forward. In 4 days, we mobilised 750,000 people to step forward to volunteer to support the NHS at its highest level of demand. There is no shortage of people who want to step forward to support health and social care reform, but it's about how do we harness that and play it forward. Let's not look back in 2022 and be as sad about the spirit of 2012 in terms of volunteering for the Olympics. As volunteering during COVID. There are so many people who want to help with recovery, and organisations like Royal Voluntary Service can really help you to do that, along with St John's, etc.
Okay, actually, let's have a quick answer to that, because that's a good point. I don't know, probably there are people in this room who volunteered when the call went up. In the end, not everybody was used, but it showed an incredible desire, didn't it, to help out on a voluntary basis. Is that something you might look at harnessing? Or?
Yeah, no, absolutely. I mean, first of all, Catherine, thanks for what you said. Thanks for raising the role of volunteers. We would not have got through this without the volunteers. We just would not have, right? And right at the start of the pandemic, helping people, especially those that were isolating, that couldn't leave their home, through to in the hospitals themselves, and obviously the vaccination centres. In the time I've been in this job, the last 3 months, I've met some amazing volunteers. And it's not just the help that the importance of the obvious, which is the help they're provided, the NHS and in the care sector, there were volunteers, but also they get so much out of it as well, and you'll know that. But you asked about parity of esteem. This is, all I would say is watch this space.
Okay, let's take 3 questions. I've been gabbing on so much. Right, Adrian Mildridge.
Adrian Mildridge from The Economist. The most obvious way to raise productivity in the health service is to move from in-person meetings with your GP to dealing with them on the phone or via computer. Do you intend to have more of that in the future?
Okay, good question. Sir, the Health Service Journal?
Yeah. Hi, Dave West from Health Service Journal. We're a magazine for healthcare leaders, so we're interested in your review of health and social care leadership, and have written recently an editorial about the problems of getting the best leaders into the most troubled areas, actually. But I just wondered, in your sort of few months as Health Secretary, what have you seen that represents the best NHS leadership as you see it, and what have you seen as the more troubled? And there have been quite a few attempts at leadership reviews more recently than 40 years ago. Why do you think yours will differ and succeed where those have failed?
Good. And the third question, just behind you.
Hello, Jessica Hill, Local Government Chronicle. I was also going to ask you about the independent review of health and social care, but from the perspective of local government, we can understand why there might be efficiency savings needed in the NHS, but social care's already had a lot of money taken out of it in the last 10 years. So I guess some people would argue, where would you make efficiency savings within social care? Is your review going to have much more of a focus on NHS efficiency savings, or are you still looking to make efficiency savings in social care?
Okay. Yeah, thank you. Adrian, your question. There's a role for remote consultations when it comes to healthcare. I'm not just talking about whether it's primary care, through GPs. There's a lot more, during the pandemic, there are understandably a lot more remote consultations throughout the NHS. And I suspect, in fact, I know that from speaking to the clinicians that a lot of that will continue. And it continues because, I don't think this is surprising at all, that you find a lot of people that actually prefer it. You know, I was at a hospital just a couple of days ago where it was explained to me that by necessity during the pandemic, they moved to, it was a mental health trust, they moved to remote consultations for most of their patients for that trust. And they found actually they worked a lot better than they would have thought. They hadn't really tried it before. The patients have liked it, the feedback's good, and it works for everyone. So I think that, yes, when we look ahead post-pandemic, there will be remote consultations. And I think as long as that is something that clinically is the right outcome and it works for people and that's what they want, I see no problem with that at all. Dave, your question on leadership. And the first thing was Dave. Dave, you should speak to Sir General Gordon Messenger. And as you said, you've been looking at this for a while. It'd be good to get that in. What makes this different is that I haven't published the terms of reference just yet. They're coming out in the next week or so. But it's Gordon with Dame Linda Pollard as well. What I think is one of our outstanding health leaders. And there'll be a whole team supporting them of both clinicians and others. And it's going to be quite a quick report over the next 4 months. It's going to be very wide-ranging on NHS and social care. I don't think there's been one done before on NHS and social care together. And when I get that report, the idea would be to implement the recommendations very quickly as well. And so I think the way it's been approached is something I think that hasn't been done since I think 1983 when Margaret Thatcher commissioned a similar report, and obviously a lot has changed since then. And the next question, was it Jessica, on savings from social care? In fact, my motive when it comes to social care is I'm not being motivated by looking for savings in social care. I think the social care sector has had a really tough time over the last few years. I say it's having been also local government secretary and worked closely with that sector from the local government perspective. And I think that what is actually required, there's reform required, especially on the integration side, but there is definitely a need for more investment in social care. And this recent sort of funding that we've set out, it's about investment through the local councils, an extra $1 billion to have a fairer cost of care. It's about workforce training. There's never been a budget for workforce training, especially of $500 million, which we set aside to work with the sector on that. And then also the support for the sort of so-called DILNOT type reforms later as well.
Okay, let's take 3 more from this side this time. Again,
Hi, Emma Mee. I'm a GP trainee in Oxford. You talked about regional disparities, and I think regional inequities in healthcare access is a big problem, and the primary reason for that is personnel. I believe that there are lots of things that, for example, in junior doctor medical recruitment, it's a very national system run by HEE, Health Education England, and I believe there's a lot of things that could be done that doesn't cost money, creative ways that you could redeploy talent, and including top talent to underdoctored areas, and like, for example, flexibility with academic trainees, for example. And so the question is that, and I think this could be applied also to other kind of business as usual processes in HEE and NHS England. Do you think that having more generic regional inequities impact assessments, I suppose, is a good idea?
Okay. Can you pass the mic on to somebody else? Anyone?
Yeah. Hi there. I'm Sean Walsh from Cancer Research UK. One of the very welcome commitments in the Conservative Manifesto was to improve cancer survival in this country. Sadly, after decades of progress, that could actually slip backwards. And one of the key challenges is around workforce and enough people working in diagnostics to diagnose cancers early enough to improve treatment options. I wonder if you could just talk a little bit about your plans for the NHS workforce and how you plan to build capacity to better serve demand.
Okay, and last question at the front here.
Hi, I'm Emily. I'm a medical student at Oxford.
2 of you, great.
No, I'm still a student, so I'm basically a baby. She is actually
But you're both called Emily.
But yeah, so education is the route forward in health. I fully believe that, and especially in the field of mental health, investing in our education is almost the best thing we can do long term. So what plans for reform of psychiatric education for medical students do you see going forward?
Okay, thank you. If I could turn to Emily, behind you, Emily, the first question. GP, thank you for being training as a GP. We need a lot more GPs. And that is part of the answer, and the gentleman earlier as well. There's a big focus on that. In terms of redeploying your talent, as you put it, I think that is something I've been spending quite a bit of time on recently, and it goes to the point I was discussing with Fraser earlier about the health inequalities that we see. That sadly, some of the poorer areas in the country are very under-doctored. And I've asked for more evidence on why that is, and I'm getting all sorts of sort of reasons for it now. I haven't finished that piece of work at this point, but there are some quite unusual things that are coming up. So, for example, recently there was a piece of work that I saw that talked about because, as you know, all GPs are sort of private practices commissioned by the NHS, and a lot of GPs end up buying their practices and they have an investment in property. And so they take a view on property in areas, and generally if it's a more prosperous area, they think the value will rise. If it's a less prosperous area, and so how property really impacts whether you get doctors in a certain area or not. And I don't think people have sort of spent much time thinking about things like this before. It's just one example of things that I want to look at properly and address. Sean, you talked. Thank you for raising cancer survival. You're right, and I touched on it earlier about during the pandemic. Sadly, we went backwards on that. It happened the world over. It's not unique to the UK, but it has always remained a priority and absolutely will, especially in the recovery and especially when it comes to diagnostics. You mentioned that. In terms of workforce capacity, whether it's GPs, it's junior doctors, it's nurses, we need a lot more. What am I doing about it? There's recruitment programs already in place long before I arrived in work and in this job, and I'm supporting those. I've been looking at what more we can do also to encourage people that are leaving at the other end to not leave so early, and give them more flexible working opportunities, and to look at what might help there. But also international recruitment is important as well. I went just today, this morning, I went to the GMC's assessment centre that's actually headquartered here in Manchester, just 10 minutes away, to look at what they're doing and seeing what kind of work more I can do to try and support that. So those are all the different avenues I'm looking at.
Okay, I think Sajid's got to go actually. So can I ask one question?
Oh, sorry, I didn't answer Emily.
No,
sorry.
Emily, sorry, you didn't.
Oh, sorry,
Emily.
Oh, sorry. Sorry, I just thought they were. No. Just thank you for thank you for being a student, and your important point about investing in education. HEE. That's that for those people who don't know, that's the part of the department that looks at the long-term needs for education in healthcare. That I've asked them, and we're working closely with them on a strategy for long-term sort of strategy for healthcare and education needs, working with the universities. I do actually think there's a whole bunch of changes that we can make. I don't want to just quite say what they are now, but I do agree with your point about the importance of education and our approach to it, and making sure it's consistent with our workforce needs. Thank you.
I'm going to sneak in one last question. Remind me of the official advice on face masks right now.
The official advice is be cautious and make your own decision.
Isn't it a bit more detailed, isn't it, that you should wear face masks in enclosed spaces?
It's about being cautious and make your own decision based on your risk assessment.
Really? It's not more detailed than that now?
No, it's not more detailed than that.
Okay. Well, thank you very much for joining us. I appreciate your help.
Thank you. Thank you very much.